we can call our assembly members and tell them that we want this. You guys have the power that way. They are not, you know, untouchable celebrities. You have every right. You can go and call them, call their office, talk to their staff. You can call them more than once. You can call them once a week. You could become friends with them. And not just for CalCare, but for other things you're important. That's really important. Democracy takes participation. So participate. And with that, I'm just going to go back. I know we had a little Facebook issue. We should be back. I think we're back up on Facebook. So sorry about that, people in Facebook land. We had a little Facebook issue. Like I said, today is just the tech issue. I don't see any questions. Anybody have questions? Dr. Bill?
Not a question, but I just want to add once again, like you said, to get more support for the bill. You know, you can think kind of strategically and actually try and influence those members of the various committees of jurisdiction, right? So obviously the health committee, ways and means, you know, budget people, rules committees, things like that. Or just generally applying, you know, pressure or just voicing your support for it with your own member of the assembly. Now, clearly we need every assembly member, we need to try and influence every assembly member, and even the ones who are not on committees, to try and push this forward. Also, state senators can influence the assembly members, so they can cross over the other house. And if there are strong advocates on the Senate side, just because it's starting on the Assembly side, doesn't mean that senators can't also be, you know, kind of lobbied or you know, pushed by us to push those members of the Assembly who may not be on board at this point. And I always the third point I would make is that when a member is on a committee, they're no longer just represent their own district, okay? They represent the entire state being on that committee. So, you know, if they're on the health committee, it's not just their district, it's not just their assembly district or Senate district that they represent, kind of like being the speaker of the assembly or the president pro tem of the Senate. At that point, you represent the whole state. So, you know, so I don't take no for an answer. If they say, you know, that well, you're not a constituent, you just say, well, I'm calling because that member of the assembly, whoever that is on the committee that will hear the bill. And I think that's an important distinction to make.
Exactly. And so, Smar, I saw your question about, are there text banking, phone banking events opportunity to pass this bill? Yes, there will be coming up. Like I said, and I was telling Ron about this, we jumped out ahead. Like, this isn't our first rodeo with single payer healthcare legislation. This is my second rodeo, actually. And some of you guys, this is more than your second. This might, I think, third or fourth rodeo on this single payer healthcare bill. So that lets you know, single payer healthcare is not a revolutionary thing that just came about. Only a couple of years ago were we fighting for another bill called SB 562. And so, but we're very far ahead on it because we already knew what we're going to be kind of up against. And so the text banking, phone banking has not started quite yet. We are, you know, I think on July 24th, the March for Medicare for All, which is supposed to be for the national Medicare for all, but you know, I mean, if you just happen to hear AB 1400 here and there, yeah. And then also CNA is ramping up too. And I think CNA will be hosting text banking, phone banking events, which I'm sure we, our organizations will be, you know, also assisting and promoting with as well. And I mean, I'm sure we will too. And we'll be promoting that when we get events rolling like text banking, phone banking, we will definitely be promoting via our social media pages. And so, but with that being said, the good thing about this is that we have time to learn. So when people come and say, well, what about this? And what about that? I know this bill, like you are not going to pull the veil over my eyes. And so we'll be so knowledgeable and so ready that we'll be able to answer those questions in the community. And so will you. You'll be ready to answer those questions. you won't have to come back and say, you know what, I got faced with this question, I didn't know the answer to it. You'll already know. And if you do, of course, you can always come back and say, I got faced with this question, I didn't know the answer to it. And then hopefully we will be also a good resource for our elected officials too, who are on board with this. And then, yes, they, as elected officials, do town halls. Now that people are becoming more public, thanks, Dr. Bill, for putting that in the chat. But people are going out and being a little bit more public. So if you know that your elected official, your assembly member is having a constituent town hall, join it and just, ask that question. Say, hey, I know this healthcare bill is going to be coming up in January. Are you supporting it? And so that's something that you can do as well. Just kind of we're just trying to make the presence known. We're just definitely making the presence known right now. But then trust me, by the time the fall hits, it's going to be like crazy. So take a breath, get a breather, because once fall comes, we're going.
Can you hear me better now?
Yeah.
Is that a little better? Because I sort of switch up. But in thinking about the problems I was just having with computer network, it made me think of something Jeanna had mentioned, which is narrow networks. And what is that all about? And what would be the difference between our current situation with networks and what would the network be under AB 1400? So, because you mentioned that, Jeanna, a little bit in the intro. And so let me say something about what's out there right now. So one thing that came up this week, and this comes up many weeks, is about a patient of mine who wanted to move up her follow-up because she's about to lose the insurance at the place that allows her to see me at the place where I see her. And that is like a really common occurrence all over the place, which is that people's insurance changes and now they can't see the doctors anymore. And we'll try to figure out a way to help her. So just so you know, I don't just sit and just idly let that happen. But overall, there's this problem, which is that there are a lot of people with no insurance, millions in California, but there's also a lot of people with insurance. And there's actually way more of those people than people without insurance. But a lot of the people with insurance have big barriers to getting care that they need. And there's a whole lot of those barriers, co-payments, money barriers, all kinds of things. But one of them is this thing about networks. So that insurers will only pay people maybe only on like best terms, pay people who are in that network. And that may sometimes be a really burdensome situation. In other words, those networks can be so narrow that somebody can't find somebody who will take care of them or their problem. Or another thing that has been proven to happen again and again, and I think there was a news story about this happening recently all over the place, is that a network or like an insurer will put out a list of the people who are like in their network, but it turns out it's like a ghost list. Like a lot of the people aren't actually available or aren't taking new patients, or they died, or they moved somewhere away, or like somewhere, there's a problem there. And especially for a lot of patients who get their insurance through some of our public programs like Medi-Cal, administered then through insurance companies, some of their networks are super narrow. So that's a really big problem. It makes people have to go see people they don't know, or it's a bunch of ways that it really harms patients. And so I think Rich is posting a link to that story. But that story is a story it's a repeated story. So now let's consider AB 1400. So if AB 1400 passed and was enacted, almost every single healthcare provider in the state would be in the CalCare network. Now, formally speaking, people, according to the bill, like sign a contract to be in the network. But without going into tons of details, let me just say that the law makes it so that overwhelmingly almost everybody who does healthcare, with very few exceptions, would be in the network. And you no longer would have that problem, which is to people, I think, for example, in other countries, a very strange problem, right? Like the notion that there's some people you can go see, but other people you can't really go see. Like that isn't usually a thing in most places. So just want to say a little bit about networks, since I was thinking about networks.
Yeah, and that is exactly why and right there in the 7 basic principles, it is everybody in, nobody out. And you should not have to worry about network. And actually, another thing, I'm going through this right now. And you brought network, and actually, as you were speaking, I'm logging into my Anthem account because I was referred to an ophthalmologist to fix something with my retina. And I'm like, wait a minute, is that ophthalmologist a network? I like legitimately, I'm logged into Anthem right now, looking up if this ophthalmologist I just got referred to is in my network, because they just referred it and it's in, and I wasn't thinking, because I'm just finding out, like, what do you mean? Like, this is what patients are going through. I'm a patient. You just told me I had no problems, and you just told me I have a hole in my retina. And I'm like, what? Like, that sounds terrible. Like, what is wrong? And then they're like, okay, yes, you need to see this ophthalmologist. I want you to see them urgently. And in my mind is processing what's wrong with my retina. What could go wrong? Am I going to lose my vision? What would be needed? What do I need to do? And then I get this referral, and I'm like, okay, yeah, I'm going to call them right now, and get this appointment. And now here comes the second thought. Wait a minute. Is this a network? Am I going to have to pay for this? I've already paid $400 to just get to find out I had a hole in my retina. So, so this is what's going on. And this is why we are here today fighting for this, because who couldn't have afforded, people who couldn't afford that $400 would have never found out that they had this issue. And then that means that maybe it gets worse. And then eventually, you have a retinal detachment. And then eventually that means you lose your vision. And if you're a working person, that means you can't work anymore. You can't take care of your family anymore. You're no longer, actually being productive because you have vision loss, and it's not your fault. It's not your fault at all. So like I said, right now, I'm going to go to Dr. Bill as I'm looking at Anthem to see if this doctor is a network.
So thanks. I just wanted to add to what Ron was saying and what you were saying, Jeanna, that networks are not group practices. Okay, so group model practice, I see Carol's nodding too. So group model practices, and that could be Kaiser, and if somebody's suing Kaiser, it's probably because it's their insurance network. I haven't read that article yet, but I'll read it. So it's, Kaiser is both. It's an insurance network, and it's also a group model practice. But let's say you wanted to go to Scripps Institute, or you wanted to go to UCLA, or or I don't know, the Mayo Clinic or Puget Sound or something like that. These are large group model practices. Some of them are teaching institutions with, really big, like we call it doctor by committee instead of committed. These are big groups that have big committees that decide on best practices and, extensive. They're not only going over scientific research to decide on their practices, they're doing the research to decide on their practices. They're basically, there's a term in the business called standard of care in the community, right? They create those standards of care in the community. So you might want to go to one of those. They're very impersonal. You never see the same doctor twice, I'm sure, at the Mayo Clinic. But, a large group model practice like Kaiser is somewhere in between that and a solo practice type of, a model of practice. So that's different than an insurance network that says you are required to go to see these doctors because they're the ones who follow our rules on what they can or can't do or practice. And the group model decides on best practices based on their, their internal committees and that kind of discussion. And hopefully, once a group like Kaiser, for example, is liberated from their insurance side, then they can just simply appeal to people based on the quality of work that they do and care that they provide to people, not some faulty financial product like an insurance plan that may include, co-pays, deductibles, other kinds of things that actually undermine the good work of the providers in their system.
Right. Yeah, absolutely. I think, and I love what you just said, liberated. This is a liberation bill, like liberation is coming in so many forms here in the United States of this part of America. I say this part of America because we do know North America is a continent and not just one country. Anyway, so I just wanted to, like I said, I just love that liberation. It just gets me feeling all feisty when I hear liberation. But I just wanted to go to Chris's Facebook question really quick about, would there be a penalty for changing which doctor you go to, and how would that be handled? And I don't know if you're talking about under CalCare, Chris. No, she's not in the Zoom, Roni. She's back on Facebook. Or were you talking about what I was saying about my ophthalmologist if he was out of network? Under CalCare, there would be no penalties, of course. But right now, if I were to find out this ophthalmologist was not in network and need to change, I would have to find out what ophthalmologist is in network, call my optometrist back and see if I could, just have this referral go to that particular provider, or if she knows one that's in this network. And so once again, delaying care for something that I was told is an urgent issue while I try to fight to get something in network. And which I will do because I've done this before, and I don't want to get hit with some out of network fees. So that's just to answer that. I wasn't sure if you were meaning CalCare or what I was going through right now, but yes, if you have a referral to a specialist, and this is something that sometimes primary doctors and things they don't immediately think about. That's why people like myself, which are case management, jump in. This is kind of our lane, because the doctor just looks to the case manager and it says, I need them to go to this doctor. And then I come back and say, oh, by the way, that I checked, it's not in their network. Do you know someone else that I can look up, or something like that, and then going to the second question, I saw that Chris was saying your ophthalmologist, said that, if you lived in a country with single payer, getting a procedure like an intraocular lens change would not be covered. And if that's our take. So, I mean, before I will give my opinion on that. So when it comes to procedures, like, specialized procedures, even under a single payer system, there has to be necessity, right? And if it's an elective thing, like I like to use Brazilian butt lifts because we know Brazilian butt lifts are pretty elective, right? That's a choice. You want to get a Brazilian butt lift. It's not that you need a Brazilian butt lift. Maybe you need to do some squats. I don't know. But I like to say Brazilian butt lift because there are definitely other procedures that can be medical necessary. So even under CalCare, we will have to look at medical necessity. No, CalCare is not going to be funding, Brazilian butt lifts and things like that as just because you want one. But if something happened to you and plastics is saying you need this because you got, a bear came after you and took off a butt cheek or something, then maybe you might need to get that done, to have an implant there because you were attacked by a bear. That's medical necessity. Now, with the intraocular lens change, like I said, it goes back to medical necessity. I would probably let one of the docs speak more on this, but from the case management, utilization management side, we even, like I said, under CalCare, there will still be guidelines that we would have to, make sure it meets medical necessity. Like I said, if your doctor says that you need this, just like in the 7 basic principles, your doctor saying you need this, then, it should be covered as long as your doctor is not trying to say that you need a Brazilian butt lift. But at the same time, like I said, I'll let, one of the docs speak on. Ron, you want to go add to that?
Yeah. Well, so like Chris, this is just so people may not have seen the question, but Chris we got in the chat from Facebook that Chris Shimizu, and hello out there, Chris, had talked to, I think, her ophthalmologist And somehow the topic of like lens transplants, so pretty specialized procedure, came up in discussion. And he had said to her, well, like in other single payer countries, that wouldn't have been covered. And so then would that be covered under AB1400 CalCare? So the first thing is, if there's a section in the bill that lists it lists all the covered services, but it's, you know, every known possible service would itself be like the phone book, basically, incredibly long. So it has a whole set, it has principles, which is to cover all medically necessary stuff. And then a whole bunch of stuff that's listed and spelled out. And that list is not so exhaustive that it would be, I think you'd look at it and say, 'cause it doesn't say anything about lens transplants, but there's a whole bunch of other stuff. It doesn't say anything about all kinds of stuff that would presume to be covered. So, but I think a couple of things. So one is that if you compare us to other countries, see, one of the things is that we have been willing to spend way more as a country and as a state, for, I guess that way, on healthcare. We spend it incredibly poorly, right? We spend it on a bunch of things like insurance company overhead, profits, like exorbitant pharmaceutical costs, a whole bunch of stuff that isn't really healthcare and doesn't really help people. But still, overall, we've been willing to commit a lot of money to this, to healthcare, and both because the bill spells out that medically necessary things, and if the only way you can see it is with a lens transplant, I don't think anybody would dispute that as medically necessary. Then I think at least the intent of the bill is that would be covered, and that ophthalmologist is wrong, because what that ophthalmologist is doing is comparing our system to some country where maybe they spend way less on healthcare overall. Now, how are they? It still should be mentioned that lots of countries that spend way less on healthcare overall and cover everybody tend to get better results, do get better results than we do in the United States and spend less. But I believe, and I think we have shown we have the money to do that we would have the most generous single payer program in the world. I think so.
And so I just want to add to that, because I'm in the bill. Once again, you guys can't see it because it's white. There we go. I'm in the bill. And so under Chapter 4, where it talks about benefits, I mean, when it comes to vision, and this is something Medicare as it stands right now doesn't cover vision, just putting that out there. So you can't just go get your glasses and stuff done under Medicare. Now it will cover ophthalmology, like you have a medically necessary cataract that needs to be removed or something like that, medically necessary, because a lot of times this is how grimy, especially under managed Medicare Part C, the insurance companies may say, well, that might not necessarily too bad right now for that cataract to be removed. And so that, once again, loophole. Anyway, so right now in the bill, it just says oral health, audiology, and vision services. And so, like I said, I know that that's really broad, but at the same time, of course, if they went down every, it's like a big tree, like every tree has a branch, vision is a tree or part of a big limb that has many branches when it comes to vision. But it does also say that, of course, whatever is already covered under Medicare, Medi-Cal, CHIP, that's going to be your foundation, right? So if the service is already being provided under these current enacted programs, CalCare, that's the minimum, okay? So that's the floor right now. What's covered under Medicare, Medi-Cal, and CHIP is the floor of CalCare. It is not the ceiling. So that's what's so great about this. This is our basic benefits are the floor. So we are going to build upon this. But let's say, for example, there is something that isn't covered. In the bill, it does say that the board, which will be built once we pass CalCare, shall on a regular basis or at least annually evaluate whether benefits under CalCare should be expanded or adjusted to promote health of members in California residents, account for changes in medical practice and new information from medical research, or respond to relevant developments in health science. And also the board is also responsible for creating an appeal process. So not only is the board going to be reviewing this stuff at least annually to make sure that they're staying on top of everything that needs to be covered and we need to be offering under CalCare, but if something isn't covered, your doctor will be able to make an appeal. And that appeal process it should be more streamlined. If I have anything to do with it, I'm going to make sure that appeal process is not about to be what the appeals process is right now, because trust me, those are ugly. Rich, I see you laughing because I'm pretty sure you kind of know what an appeals process looks like. It is not pretty. So I just want to add that in there too. Dr. Bill, you had your hand up?
Again, great job so far. I would just add that, because this can sound kind of strange to people, wow, who decides these things? This is something that's already being done. When we say Medicare for all, okay, Medicare does this. The VA does this, so this is not some strange new thing we're talking about where, a board or, panels of doctors. I mean, the politicians like to introduce these loaded phrases like death panels and that kind of thing. But actually, it's been commercial interests who have done this with commercial insurance. But we've also had public interests who've done this. And, for example, the outcomes, medical outcomes of the Veterans Administration service are excellent. And they do that. They review what are considered to be all essential medical services. So this can be done. It is currently being done. We're just about we're talking about expanding it to everyone in California, or when it becomes, federal, expanding it to everybody in America.
Yeah, exactly. And like I said, what the current system is, the current public system, let me rephrase, current public system with your Medicare, Medi-Cal CHIP. And CHIP is the child's health insurance program, by the way, if people are not sure what I meant by CHIP. That's the floor. Okay. So they have to provide that at a bare minimum. Right. But they're providing it all together. So I guess another thing, while I don't see any questions right now, but another good thing to mention about this is that with AB 1400, it's taking Medicare, Medi-Cal, CHIP, Title IV, ACA, everything, all these different things, putting them all together under one roof, right? And one thing about, and I like to call it Medi-Medi, but it's actually better than Medi-Medi, and Medicare, that's Medicare, Medi-Cal. And so it's basically like for patients who are seniors or, have Medicare or, disabled or something, and they have low enough income, they qualify for Medi-Cal, they get a dual insurance called Medi-Medi. And that means that if Medicare doesn't cover it, Medi-Cal picks it up. And while that sounds good, but keep in mind the issues we have with Medi-Cal, that apartheid system. Not all providers take Medi-Cal, not all providers even want to see it because of the rates being paid so low. So just because they're covered in almost not quite 100%, I would say maybe 90. There's still things that fall through the cracks, even for Medi-Medi. It's still an apartheid system because if Medicare is not covering it, now Medi-Cal's paying that out. And like I said, your network, going back to the network and who's going to be able to see you and who wants to see you. And unfortunately, I put that want there because there are a lot of providers out there, unfortunately, who have a quota in a sense of Medicare or Medi-Cal patients that will, they'll be like, okay, I've seen my Medi-Cals, and they'll like, my schedule's too full. They'll say, they can't refuse you, but they'll just say my schedule's too full. Right. And it's an ugly truth, it happens. And so I just want to say that with AB 1400, combining that fills up so many of these holes that patients have been falling through because they only have Medicare, or they only have Medi-Cal, or the kids only have CHIP, so it fills up all these holes. And by providing it to all Californians, now you're going to provide that care, that access to care, that equitable care for patients who, some people actually, want to work. And believe it or not, working is actually makes them lose Medi-Cal, and their current job doesn't provide benefits. Now, what world does that make sense? Make it make sense, somebody. And so they can't even go take that job that maybe they were offered because they have a family, they need insurance, and that job's not offering insurance, or the insurance is too expensive. I've been hearing this a lot lately, that Medi-Cal, I can afford Medi-Cal, but I can't afford my employer-based insurance. Once again, make it make sense, people. But under AB 1400, that person doesn't have to worry about that. They can go work, produce, and help with the California GDP, which is, of course, what all the politicians want to care about. So that is what I'm saying, is that this is an investment, not just in California and the people and the Californians. This is actually an investment for California by adding more productivity to our GDP here, and making us a more productive state. On top of that, probably going to gain some more people here in California if we can get the water running right. And so, like I said, AB 1400 is really going to open some big doors here. And I just, I encourage everyone to kind of see it from that standpoint. Wait, did I see? Oh, Dr. Bill is just giving me a thumbs up, not a hands up. Ron, were you going to add something?
Yeah, I'll just say this, which is that there's a lot of so many decisions that people make that are based on healthcare that should have nothing to do with healthcare, that if you had a plan that, and AB 1400 would do this, that guaranteed everybody healthcare no matter what, then all these decisions would be freed from that. So I'll give you some, just like, I think I mentioned this maybe a few office hours ago, but it's sort of, I've been thinking about it since then, which it was around Mother's Day. And I had been listening to some medical assistants who, by the way, are working at medical offices, but where they're not getting insurance from the office, which is actually very common, actually more often than not when your job is medical assistant by far. And so they're on Medi-Cal, and they were talking about the fact that they weren't marrying their kids' fathers, because that would then make them ineligible for Medi-Cal, but wouldn't move them into a situation where they were sure that they were going to have some kind of insurance that they could use. So you actually have people not like, is that family values? No, that is not family values, right? In other words, you should basically decide if you're going to get married, if you're going to start a business, if you're going to change jobs, if you're going to move towns, based on, do you want to get married? Do you want to start a business? Do you want to change jobs? Not, oh, I am going to lose my healthcare or not, or maybe that thing would give me better healthcare, or I'll lose good health, better healthcare that I have. That, like, there's, and when the conversation about healthcare starts to shift to, is there universal coverage? Are we covering everybody? A lot of times these, like that little issue completely disappears. So, or in the discussion, but it shouldn't, because of all the things that we've been talking about. So just mention that and keep trolling for questions.
Exactly. And that's the thing. Carol just added, is that freedom? That is not freedom. If you want to be patriotic about it, we're supposed to be, given certain unalienable rights. I don't know if they meant to include me in that when they wrote that, but I'm assuming that they did. And so unalienable rights, life, health equals life. So I'm saying that this is an unalienable right given to us in our Constitution. And so I think that maybe some people above forgot that, because life is health. And if without health and health care, how can we have life? So life, liberty, and the pursuit of happiness, getting married, that's a happy time, but you can't get married because you don't have health care. So life, you know, your pursuit of happiness, done. Life, done. So I feel like I'm being denied. Like I said, I'm not certain if that was written for me, just putting that out there. But life, liberty, and pursuit of happiness, like Dr. Bill said, starts with good health. And without that, then we do not have that. And so, like I said, right now, it does feel like we are being denied our unalienable rights. And also, you know, going into like the bill itself, it's not perfect, you know, and I was talking to our you know, esteemed superstar author, Ash Kalra, about this. We know that AB 1400 is the just creeping open the door, right? It doesn't mean that every problem will be solved with passing this, but it will be so much of a paradigm shift that, you know, I would feel like every door is about to open. I know I'm sure if this passed and Governor Newsom signs it, you may see me on the news, some crazy woman dancing in the streets in the middle of the 405. I don't know. I'll have healthcare. But anyway, but the work is going to get started after it gets signed. So while, yes, this is the fight, truthfully, a lot of the fight actually still has to happen after the bill gets signed. And that first fight is who's going to be picked on that board. You know, that's the first thing that has to happen after AB 1400 passes. Who gets on the board? Governor Newsom has signed it. He used his pretty pen, and I hope he frames it. And so, and then now he gets to appoint, there's a 9-member board. And I think 5 of those members are appointed by him, right? And granted, in the bill, it does say that they have to, you know, be, really quick, it does say that they have to all, of course, be in, you know, some form of healthcare. He can't just go pick anybody he wants. He can't put a friend of a friend in there because, well, maybe he could technically if that friend of a friend is a healthcare provider. But it does have to be a medical physician. I think one has to be a nurse, public health. I mean, honestly, I've got 9 people here right now, 9, 10. I think we have the CalCare board right here. Boom, done. CalCare board. And so, but no, so that board has to be appointed, 5 members by him, a couple by the Speaker of the Assembly, a couple by the Senate Pro Tem. And so, I mean, since we, you know, talked about amendments, if I were to slide an amendment into this bill, it would be to expand the number of members on the board to probably like 15, 5 for each section of this state, because NorCal doesn't have some of the same issues that Central Cal does. Central Cal definitely needs some representation. And then SoCal, well, you know, we're just SoCal down here. So I think that 15 would be a good, decent number because it would be good representation for each section of the state, over 9. And then, you know, but 9 members right now as written. We'll see if that changes by the time we get through with this. And so those 9 members then get to appoint a committee of 11 people. Now, this is not a paid, it's like an advisory committee. It's not even paid. You get like your per diem expense if you have to go to Sacramento or something. But, you know, it's not paid. The board is paid. How much, I do not know. But, you know, it is paid position. So that is where it starts, okay? Once CalCare is passed. And then everything in this bill where you see as to be or to be determined by the board, that is where they got to get to work. Okay. Then they got to get the waivers. Then they have, so we're really looking at a big fight where we're going to have to honestly be some watchdogs here. We're going to have to really be watching what's going on, who's going what. And that's okay, because once we get it done, then CalCare will be a beautiful thing. And then we do have some, you know, some Fed issues that we might have to look at, some state propositions that were enacted before I was born that may become an issue, but we won't know any of this until we get CalCare passed. AB 1400 has to pass before we can even start to really unpack and put in the things that or apply for things that we would need to apply for to find out if we're really going to hit this wall or these walls that may pop up or not. And when we hit the wall, then we got to figure out a way around the wall. There's always a way around the wall. Through it, under it, over, whatever, there's always a way. And so that's where I just want to, you know, I always like to emphasize that, but so much depends on just passing it, you know, before I can start handing out CalCare cards or, you know, someone hands them out. We have to get through so much. And that's where, you know, a lot of people have to really keep an eye on this. And that's where elected officials have to understand is that CalCare is just the beginning. The passage of AB 1400 is just the beginning of the real conversation and the real work. It's not saying that it's guaranteed because the board has to say that it's ready to go before it can go. And so I don't know why any elected official will say no at this point, because I'm like, really? There's no harm in it. You're actually just going to allow some people to have to do a lot of hard work that isn't them, but somebody will.
And maybe it's worth comparing, like, you can look at the board structure that's in the bill and say, could this be better? Could that be better? And I'm sure anybody who looked at it would have thoughts, and their thoughts might be different. And I agree with pretty much everything you're saying. But it's also worth comparing that situation to the current situation, in which there's like almost no accountability for anything in our healthcare system. And in fact, try hard to if you have a problem with something with your health plan, like it's super hard to even like get somebody on the phone. Like if you're like start with, I have a problem with my plan, and you're trying, you see what the phone tree is like if you have that problem, much less to actually get to somebody and has decision-making authority, right? So it's pretty hard to imagine that, healthcare is always a charged thing in any country and in any state or any place, because it's important to people. And it will always have, I think, controversy. There will always be people who think we should be doing more of this, we should be doing more of that, we should be doing less of this, less of that. Those questions themselves will never go away. But one of the things that really fails us right now is it's very hard to go anywhere or for individuals especially, or groups to kind of, try to get their redress for their grievances about problems with the healthcare system. So that's one of the big changes that passing a bill like AB 1400 would do. It would like locate the accountability on healthcare. I think that's very powerful. I think it has been with Medicare itself, but over time.
I see a question from Chris and from Facebook. Under AB 1400, who would get to decide what may or may not be covered, like the interocular lens change or Brazilian butt lift, and how long would it take to get an answer? That is a good question. That going back to the board. The board would be who is going to, well, I mean, like I said before, the bottom, okay, the floor of AB 1400 is what's currently enacted right now. Current covered services under ACA, CHIP, Medi-Cal, and Medicare all have to be covered under AB 1400 too. So AB 1400 can't remove any services from that's currently a covered service under these programs, right? Now, regarding the, interocular lens changes, Brazilian butt lifts, now that is where the board will have to, decide what if they want to add something that isn't covered under those services, add that in. And that goes back to what I was saying about that annual review, to see, like, looking at the research. And I think Japan does this too. I think a lot of the single payer countries do this kind of annual review to see what, if their service is not covered, do they need to be covered? If they're, it's kind of like, it's always like a flow. It's nothing solid and rigid here. Okay. Everything can be reviewed. Everything can be something can be added, but they are not allowed to not cover something that is covered under those programs already. And how long will it take to get an answer? It better not be as long as it takes now. Oh, go ahead, Ron. And then I see Rich, I see you have your hand up too.
Well, although I think that what you're, there's two things there. So you have like formulary, and procedures, and maybe other types of services. And the bill talks some about formulary. And in fact, actually at our last office hours, we talked a lot about one very special drug. It was essentially like a gene therapy drug. And then, procedures and other services are kind of obviously another thing that are described well in the bill. And I just agree with what Jeanna said. So one thing is that because one of the things the bill does is it captures sort of the funding from federal programs, it requires that to happen, basically, or that's the main way. It actually envisions a little alternative to that in some cases, but primarily what it envisions is capturing the federal money. And to do that, it has to cover all the same stuff any federal programs would already cover. Then the bill has its list of things that it covers too. And so those together are the floor, I think, because you have the legislatively set stuff and then the things in other programs. And then you have whatever the board says. And then that will define, I think, the covered services. And that will be a never ending process, like you said. But it also, any system like this would still have, it will always have to have appeals processes of some kind, right? Like because you just can't anticipate everything ahead of time. And that's true. So I just want to add that on.
Oh, thank you. Rich?
Yeah, I just to sort of answer that question. I don't have my AB1400 text in front of me like you do, and nor do I have a binder like Dr. Dean. But I think I remember that there were two processes in terms of appeals that was written into the bill itself. One of which you had already mentioned, which is I think there's an annual appeal in which you can sort of add procedures or add certain formulary medications or treatments into the formulary, into the procedures list, et cetera, which occurs, I think, every year. They'll review that, and I think I don't know if it was the 9-member board or the 11-member board that went over that. And then there's also a special appeals process for, certain things that need a little bit more rapidity. And I think, if I remember correctly, that was something that could, and don't quote me on this, I think it was 30 days was the time of the more emergent appeals process. So that they did write into the bill itself sort of a faster way to get things appealed. And I agree with you, Ron, that it truly isn't just Medicare's the base or the floor. It's that plus more, because there's a lot more that is offered, and the bill actually details certain other things that are going to be made available. Even in cases like the Brazilian butt lift or the interocular lens change, I'm not so certain that those would be things that wouldn't be flat out potentially covered, especially if they're quote unquote medically necessary. Like what Jeanna was saying, if a bear bit off your butt and you need a butt lift, you need a butt lift. I think that the more, the things that would be questionable would be the things that, have more of a questionable sort of need for it, or questionable science behind it, right? So like, certain, I don't know, unproven therapies might not be on the list yet, and that might be something that needs to be looked at by the board.
Right. Although I think the implication, I actually could not even begin to define what a Brazilian butt lift is, but I guess I can imagine. But the implication there is it's a cosmetic procedure, right? It's to make your butt look like the Brazilian ideal, whatever. And so I think it's probably right that there's sort of like no health plans that really cover cosmetics, and I think most people would agree that that's right. There's obviously some things that blur lines at times, and any health system has to navigate those things. But I think it's
fair to say that if it were covered now, it's going to be covered under AB1400 CalCare, and if it's not covered now, there's a possibility that it might be covered, or it's not covered just like how it is now. Like, if you're going to go get plastic surgery for aesthetic reasons, that's not going to be covered now. And there are avenues in which you can still get that done, but you wouldn't be using CalCare money, I would assume, right?
No, absolutely. Right. So when you start, so people can still, so healthcare providers can still do anything they want, and they're not restricted from providing services that aren't covered. and then they can take cash for uncovered services. But most of those things would be medically non-necessary things. And I think that's reasonable, and more than reasonable. And I actually think the way you said that, which was right, which is understanding what's in the bill and the intent and the amount of resources that could be made available to healthcare for people, by not wasting what we do now. It's fairly clear that I think almost nobody would take any steps backwards, maybe nobody, on what was available to them. And I don't think that's just like hyperbole because I'm like really for this bill. I am for this bill, but it's just, that's the intent. And our resources that we commit to healthcare are vast, and they could be doing a much better job. And anyhow, that's one of the reasons to do this, right? Because it's not purely like AB 1400 is not in that sense like purely kind of like an ideological move or something. It's a more efficient way to just do health for a state.
Right. Just really quick, I was looking it up, Rich, about the 30-day thing. And I mean, granted, I just did a quick control find thing. The 30-day appeal was for the global budget. So an institutional provider can appeal the board and appeal with the administration about their global budget and stuff like that. And they should get a response within 30 days. But the board can initially basically give them a emergency kind of like fund or something like that. That's what I was saying. Now, granted, that's just I just did a quick scan, but when I typed in the appeals process, that was something that had popped up. But I'll if there is something else, I will look a little bit more into that.
You and your control find.
All right, Dr. Bill.
Trusty control find. I'm looking at my keyboard. Where is the find key?
Well, it's just like Control F, or if you have a Mac, Command F.
I don't. So I wanted to kind of do a rip off of Rich's point about those things medically necessary, like Jeanna's talking about, or essential medical services, right? So not frivolous things, not the clearly elective or something that's like, just for cosmetic, purely cosmetic reasons. I mean, there are reconstructive, procedures, obviously, but those things, as you mentioned, Rich, that are of kind of dubious scientific nature, that are not necessarily have evidence to support their use. And who is it that you want to be in the decision-making capacity for that? And I'll give you a rather famous example. Our good friend in the movement, Wendell Pyre, of course, worked for Cigna Health Insurance. And the reason that he quit was a famous case of a young Southern Californian by the name of Natalie Sarkeesian, who died. She was only 17, so a child. She died of fulminant liver failure and had applied to Cigna, I think it was 7 times. She was refused a liver transplant at the time. And Cigna claimed over and over again that there was not enough scientific evidence to support that procedure being done for her medical condition that caused the liver failure from which she ultimately died, until, of course, Wendell, I believe, says they finally authorized her liver transplant on the day that she died. So I would just ask you, and I think we need to all ask the public, who should make those decisions? A commercial interest like an insurance company, or a public interest like a board that is determined by, you know, elected officials, but also written into law, that could be people like, you know, judges, professionals, other people, as opposed to someone whose stated interest is their shareholders and their commercial bottom line. I would never trust an insurance company to make those decisions, and yet that's what we have right now. We have insurance companies making those decisions as to what is legitimate science, what is legitimate scientific evidence-based medical practice in this country or in California.
So I just wanted to add to that really quick, because just to give, you know, some talking points, because I know, you know, from that side, you know, that in the insurance companies, utilization management, there are nurses, there's doctors, there, you know, and they're the ones reviewing these cases, right? For medical necessity, all that stuff. So typically, if it's a cut and dry case, like it's an HMO review, you know, and it meets guidelines, pass it. Sometimes the doctor doesn't even need to review it, just gets passed at the nurse level. But something like the Natalie Sarkeesian case, where maybe, you know, she was on the borderline, she was on that, pushing that borderline of like, okay, there might not be a whole lot more evidence there. That's where these intricacies and these tricks and this administrative bloat kick in. Okay, so if there's a gray area and their guideline isn't clear, and let's say it's a very expensive procedure, then those reviewers, and I'm going to say there are some good ones with good hearts. Like it's not just a bunch of evil people in these places. Like I said, the worker should not suffer for the sake of the leadership, and because it's the leadership pressuring them. And so, you know, so if there's a gray area, and let's say the nurse reviews this case, okay, I'm going to use this Natalie Sarkeesian case, and I'm just going to use this as a very broad spectrum. I haven't looked at her case like line for line to know what exactly it was, right? But very broad case. So let's say, you know, it's a transplant, it goes to the nurse for review, the utilization management, and, you know, the nurse is like, you know, it kind of doesn't necessarily quite meet this guideline, so now I've got to send it up to physician review. Okay, so now it's in physician review, and the physician reviewer is going through, and they're like, well, yeah, I mean, okay, she has this, maybe, you know, she's been hospitalized X amount of times, this, and this, she's had these labs, and the hospital, her providers have probably submitted this big stack of records, right, to justify why it should be approved. And so the doctor's going through, picking through what he's looking for to see if they can make it make sense and cover it. And so if there's still that gray area where it's like, well, you know, it's like, maybe, I mean, granted, with young people, to me, my heart would always make me err to the side of like, no, they have plenty of life to live. It's not like a 90-year-old, you know, she's plenty of life to live. So anyway, so then that's when you go into that physician reviewer is going to his higher up, his directors, and now they're taking this case higher. And that's where it gets, the gray areas are like, well, let's try this treatment first. Let's try that treatment first. And that's how you get how did you apply for something 7 times and get denied 7 times? Well, it's because every time it went through, denied, sent to, well, let's see if we can get this. She doesn't meet this, you know, and that's the flaw right there. That is what's killing people right there. And it wasn't for the sake of the fact that, oh, well, you know, it really was not, it was an elective case. There wasn't enough evidence to support it. It was the fact that transplants are really expensive. And the fact that they were like, well, let's try this route first. Let's try treating her with this first, treating with that first. And that is what's going on. And like I said, these are things I just witnessed. I'm just speaking truth to power from what I've seen. And so,
I'm sorry to interrupt, and I know Rich has his hand up too, but it's because you're commenting on the case that I brought up. But a transplant being expensive, you know, when we're all paying for it, that becomes irrelevant.
Exactly.
You know? And then it's no longer part of the estimation. Now none of us as healthcare providers want to do things that are unnecessary, because we know that increases the cost of healthcare in general, right? And it also subjects people to unnecessary risks. But when it's you know, it's something that's that fortunately rare, you know, like liver failure and a liver transplant, we can afford that collectively. It's like building a bridge. None of us can singularly afford to build a bridge, but together, all of us can afford to build a bridge. Same is true with this kind of situation.
And when you're not worried about profit, that's where it also, when you're not, profit is not your motive and taking care of people is your motive, that is where the decision becomes a lot easier. And Rich, I know you've had your hand up for a minute, so go ahead.
So I worked at UCLA for 4 years, and I worked very closely in the liver transplant unit. So I met quite a few people who were around that case or around during that time. And you can still feel the emotional scars that are left behind through that case. You're talking about someone, I think she was in her teens, 17, 18, something like that. And the doctors had appealed Cigna, written a letter, and tried to get them to approve of liver transplantation. And it was denied. And during the time where they were trying to continuously appeal the process, she had 2 liver transplant offers, and they had to turn those liver transplant offers away. And by the time that Cigna finally approved the transplant, she had passed. And you know, you think about, you know, the costs, right? You cost this, you know, young lady, girl, whatever, however you want to call it, her life, and you cost a lot of emotional damage and scars to all those that took care of her, all the nurses, the staff that kept her alive during the period of time while you're you know, in these process reviews. That was the cost. And Dr. Bill's right. The financial cost, if you look at it on a whole, is not great. But the problem was that the financial cost to the insurance company was too high. It was that they were looking out for their own profit margins. And so that's the difference when you're looking at when an insurance company who is profit driven is reviewing your case versus when you have a CalCare board is reviewing your case.
And thank you. That one sentence you just shared about profit driven reviewing your case, that was basically what I long-windedly was saying. So thank you you summed it up right there. It is about the motive. When you're reviewing these cases, it's about the motive here. The CalCare board, their motive is to keep people healthy because, like, you know, we know unhealthy people, you know, high medical expenses. There she is. Sorry. I was like, oh, baby. Anyway, so that is what, you know, what it really, their motive is different. And I saw, Ron, you said you had a section on appeals.
Yeah. And one of the sections, am I muted? No, I'm good. So let me just read, since, I mean, so the bill talks about this specifically, kind of the issues of what's covered and what's not covered. So, and just, you know, this is on page, for people who have the bill, it's on page 32 of the bill. So that may help somebody find this and put it in the chat. But what it says is in implementing this section, and it's a section on benefits, the board shall not remove or eliminate covered healthcare items and services under CalCare that are listed in this chapter. So one thing is the board can add stuff, but it can't take away stuff that's part of the floor concept that Jeanna was sharing. Then it says that the board shall establish a process by which healthcare professionals, other clinicians, and members may petition the board to add or expand benefits to CalCare. So that's about like what gets at, you know, what would be a good idea to add as a general policy over time. And then there's another little section, which actually, I don't think we've talked about it yet here. So it's kind of interesting. So it says the board shall establish a process by which individuals may bring a disputed healthcare item or service or a coverage decision for review to the, in capitals, independent medical review system established in the Department of Managed Healthcare pursuant to Article 5.55, there's a section of Chapter 2.2, blah, blah, Division 2 of the Health and Safety Code. So, in fact, actually, they actually decided, the bill writers, to use an appeals process that exists because the state also does some regulation of managed healthcare plans, and specifically, certainly the ones that are public. But so anyhow, I just wanted to mention that that is in the bill. In other words, the bill envisions the need to, one, define what's covered and not. Two, to have that be flexible over time in terms of that things can be added based on an understandable process. And three, that you have to be able to have systems to call audibles in individual situations where things get reviewed. And as everybody's been saying, that's done by people who aren't motivated by profit in making those decisions.
Exactly. I mean, yeah, because like I said, right now, going back to that initial, when the insurance companies will say, no, we do have medical professionals, licensed doctors making these decisions. But when you know that that decision is being made off of like, well, you know, a more profit-driven model than a care-driven model, granted, yes, there are guidelines. If a patient meets certain guidelines and it's pretty clear cut, you know, they can't really deny you. They wouldn't have a reason to. And if they would get in trouble for that if it were to, you know, come out that they denied something that met these guidelines to be covered under Medicare, Medi-Cal, ACA, whatever. But if they, like I said, a case that gets a little blurry, in which a lot of medicine does, there's a lot of blur here, you know, because every person's different. That's why medicine's always a practice. I used to always get told, if, you know, someone tells you that they are, you know, they don't practice medicine, it's perfect, run away, because it's always practice. So, you know, but that's where that trick gets put in. And that's where the rerouting of care, those delays, those repeated appeals, that's the problem there. So under CalCare, like I said, the motive is different and everything is covered. And when you have such a big pool, that transplant, that's like a drop in the bucket. Like, we're not going to be looking at, oh my God, this transplant's going to cost so much money. No, because at the same time, I can guarantee you those UCLA bills were a lot higher than probably the cost of the transplant itself. And it just, when it adds up to it, it really is. And I don't see why the insurance companies don't see it this way, but that's how it is. They send you around a big loop-de-loop of denials and appeals. Meanwhile, you're still having to get care. You're coming to the ER. You're constantly having to sit in that hospital, racking up money. And by the time you look at that final cost, likely it's probably more than if that transplant would have been approved on the first time. I see a question from Dennis in the chat. How would CalCare get around the Hyde Amendment? A friend asked me this yesterday and I brain farted. No problems with brain farts. I brain fart all the time. Ron, were you gonna?
Yeah, that actually, so first, like, it's a good question. And it may be that we need to do a little research on a couple issues, or maybe somebody here knows. But first, let me just say what the Hyde Amendment is, which is it's part of federal law that says that that the federal government won't spend money on abortions. So I'll just give a couple examples from my own experience. So I was a doctor in the Navy for a long time, and so the military won't pay for a military member's abortions, or but although I am not, I think that Medi-Cal has some way that it works around this. That's what I think we should research, because I do think. But the point of Dennis's question is that if you have a program that takes a bunch of federal money, puts it in a pot, and that pot is going to cover, and by the way, the bill does say that it will cover all like reproductive health services. I personally would add, I think it should also say cover abortion in those specific words. And that that's something I think it should be amended to say that, but there's some decisions. or there may be some decisions that are based on politics or whatever in how things are worded. But leaving that aside, I do think, but I think we need to research it, that the state of California has already figured out some workarounds on this. But I also, actually, then Carol's bringing up another really good question, which is that perpetually, there's always this question at the federal level, which is about like the funding of Planned Parenthood and, you know, like the political football of funding of Planned Parenthood or not. And I think one of the answers in the state of California is give everybody healthcare that they can take wherever they want and do whatever they want with. And now every Planned Parenthood is funded because everybody who goes to it can get, will have their care funded. But I think we do actually have to answer that Hyde Amendment question fully. I think we will, though.
Yeah, I mean, I think Planned Parenthood would be classified as an institutional provider of women's health services. And actually more than women's health services, because guys can go to Planned Parenthood too for certain, issues that I'm being very vague on that for a reason. But at the same time, that is something that could happen. But at the same, let's remember why Planned Parenthood exists. Planned Parenthood exists to create a safe space for women's health, number one, which is very good. We needed, we needed a safe space. And then thank you, Jackie, for adding that for our LGBTQ, QIA people. They needed a safe space. That's not judgmental, number one. Judgment, it is a very bad issue we have in healthcare as providers. But so Planned Parenthood existed in that space. But one of the things, providing CalCare might not immediately cure the judgmental healthcare system or the judgmental providers, but it will provide access. So there are, especially as the younger providers come up, my generation, the millennials, the Gen Zers coming through medical school and stuff like that, we have a different point of view than some of, the older generations. And so, it might be easier to find a more accepting provider and, and then under CalCare, you can go see that provider. Especially if that provider maybe can relate to you a little bit more, maybe if they're part of your community, that's even bigger. So under CalCare, you wouldn't be restricted to like, oh, there's this really great doctor, maybe in West Hollywood or something that, I heard really, he's part of my community. He does this, I would love to see him, but he's not in network. Well, guess what? Under CalCare, you just get to call him and say, hey, are you in my network? Or excuse me, do you have availability? Can you see me? And he'll be like, sure, yeah, come on in. And so, the thing is that too, we also have to consider that when we provide people access to care, like I said, the Planned Parenthood should have funding as an institutional provider. The reason why I'm saying should is because, yes, we know the name Planned Parenthood charges certain people politically for whatever reason. I do not know why they just get so riled up over Planned Parenthood. Oh, religion and politics. But don't get me, that's not what this is about. We're not going to go down that route, that separation of church and state. But anyway, so like I said, Planned Parenthood should be an institutional provider. They should be allowed to exist as a provider of women's health, of reproductive health, which is written right there in the bill. And then, you have an answer for the Hyde Amendment. And then Rich will come to you.
Yeah, it is. It's already the case that states that Medicaid in states, which in California is Medi-Cal, can decide, so Medicaid, which is a program of healthcare primarily for the poor, is a combination of state money and federal money. So the existing laws already allow individual states, if they want to use the Medicaid part of their Medicaid money, the state part, they can Medicaid or therefore Medi-Cal in California can pay for abortions. And therefore it would also be the case that likewise a bill like this would make it so that people could do that if they wanted to. So I think the answer is that abortion would be universally covered in California under AB1400. And I don't think it would face any more legal challenge than the existing Medi-Cal ability to fund abortions would. It's a great question, though.
Yeah, that was good.
Because you could, like, let me say, there are real significant like barriers in California related to our healthcare system to reproductive healthcare of all kinds right now. And so for example, a lot of folks who are uninsured, including a lot of folks who are, and a big chunk of our uninsured, maybe half, are undocumented. And so they may in particular depend on the ability of foundations and also the federal funding that goes to Planned Parenthood and things that are not that stable and also not maybe always geographically distributed well. So I do think that this is a reproductive health rights bill too. I think that's right to say that, because it essentially gives everybody the at least the money part of their benefit, because it's universal, fully universal.
Rich, you want to, you still have your hand up?
No, I was gonna, Ron already answered the high thing. Yeah, so California, that ship had already sailed because I think the courts had put in an order to follow state constitution guidelines with regards to public funding of abortion. So I think Ron's got it already.
Oh, awesome. Well, yeah. And like I said, this is a good conversation. This is very important conversation. I'm glad that it was brought up. Thank you, Dennis, for bringing that conversation to the forefront, because it is very important that as women, and that's why I say that AB 1400 is a health equity bill, because as women, we have been at the mercy of people who are not women making up our healthcare laws and saying what can be covered and what can't, and that being influenced by things like religion and personal preference. And that's not, something that should be going into creating an equitable system. And when you're representing all of America or all of California, you represent all of what everyone believes and what no matter what your color is or what your orientation is or what your income is. And unfortunately, I feel like on the political field, there's been a lot more personal preference that have been put into legislation than I would like, especially around my reproductive rights. We still are fighting the battles within certain insurance companies not covering birth control because they're a Catholic-based company. I personally have experienced that. Because they're Catholic-based insurance company that they will not cover birth control. And so under AB 1400, guess what? Doesn't matter. They can go be Catholic and do whatever they want to do, which they have the right to do somewhere else.
But, and exactly like those, when you start to get into, well, why is healthcare tied to your employment? Well, for some employers, then they now want to impose their value on how that money gets, their values on how that money gets spent, and they shouldn't be able to. But one way to meet them sort of where they are is to say, you're right, you actually shouldn't have to be the ones providing the healthcare. Goodbye, let's just give it to everybody. And that's one of the things this bill does. So like the marriage of healthcare and employment is an unhealthy marriage. Maybe it's time for a divorce. Let us support and move on. Employers move on. Healthcare move on, and be independent of each other.
No, the money is too good when we're together. It's the money. It's like they're staying together for the money. I mean, I hate to say it. I know relationships like that, but they're staying together for the money. And Rich, yeah. I saw you put annulment in there. They've been together way too long to get annulled. Unfortunately, they've been together way too long to get annulled. I see another question really quick. Is the Healthy California Commission a delay tactic? Ooh, that's a good one. Just to put that out there, commission, I won't say necessarily it's a delay tactic, right? I'm going to say that there are people who still aren't convinced, even though with the current data and evidence and other industrial countries around the world who have this system, who have had it since its inception, or who've had it for several decades, long before I was a part of this earth, they still believe that they need more evidence that this is the way to go. And, you know, while in my personal opinion, the evidence is there and it's been there, and we've got several studies. I would say the Healthy California Commission was to get people, provide people, I guess, that that evidence, more evidence that this would be a better way to go. But like Ron, I just saw what you said. What is that commission? So yeah, you want to go ahead and answer that? I feel like I've talked too much today.
No, well, not at all. You're fantastic. But so the question came from Paul, and it was, is the Healthy California Royal Commission a delay tactic? So what is that commission? So there was after the last single payer bill was killed, there was still a lot of interest in doing single payer universal health care. And there was another bill that was passed. The number now escapes me, not super important, by the legislature that said, let's create a commission to study doing a single payer in California. There's a lot more words to it. A unified financing mechanism, including that or possible other systems, but like let's form a commission. And this was while it was signed by the prior governor, but I think that's right. But our current governor, Governor Newsom, took it up and did create this commission. The commission had a budget, and it's been having these meetings. And so the meetings where there's a long delay in one of the meetings during part of the pandemic, but they've restarted. And the nominal sort of purpose of this commission is to study what it would take to do a single payer or something like that system in California. And it seems too that the governor has put some emphasis on this process. And I think that it's right to say maybe more that this commission is like a Rorschach, people's opinions of it are a little bit like a Rorschach test of what you think is the governor thinks or what you think is going on with healthcare reform. In other words, the recent meetings of this commission, I think much of the subject matter has been very favorable to single payer. Like they've been people making presentations essentially that show its benefits. They showed the downsides of our system. And so, and I think it's also true that while it isn't that there needs to be new studies on is single payer a good way to do healthcare, that's pretty clear. But that's not totally what a commission like this might do. It might also, for example, try to untangle what would be the steps needed to implement it in a state like California? Because it is true that there's never been a single state in the United States that's gone to a single payer system. That's an example. And so I think that the answer, Paul, is that many things created by government, it has maybe good, it's the product of maybe good and bad intent, and its execution may include some good and bad intent. And it may have some people who either who just see it as another way to talk about stuff and just kind of kick the can down the road, but maybe other people, and maybe that the other people who are actually believe it's gonna kind of come up with a final plan and proposal, and that will be something that the governor will take seriously and the legislature will take seriously. So I can understand anybody coming to any of those conclusions. I think there's enough evidence to support all known conclusions on that. And so, some people are sort of well, let's just not waste time with it. And then other people like to, even if they don't really believe in it, like to attend. Those are publicly open commission meetings that people can attend. And then they're on Zoom. So people can see them on Zoom. There was just one last week. It happened to be during my work day. I was unable to attend. But anyhow, this is a little bit on, it's my thoughts on the commission. And I don't know if other people have other thoughts.
Well, I think that the commission also, it will be wrapping up at the end of this year. So before we go back into the assembly with AB 1400, the commission's going to be done. So that's going to be one more excuse that's going to be out the window for people who are not on board with this. And, you know, I mean, like, it seems like their findings, it's not a hit piece on single payer for one. But it, you know, I don't think that their findings are going to be terrible to the point where the governor is going to be like, oh no, we can't, look what my commission found. But, you know, I do think that this is going to be one more hurdle that's going to be out the way before AB 1400 hits the back into the assembly in January. That will be one more less excuse that people have. Well, let's wait for the governor's commission. You know, no, governor's commission's done and done with. You know, here's their findings. You have that. By then, we would have probably also had every single talking point against everything negative they've said. And so, you know, we would have also taken one more kind of like stall tactic or excuse off the table at that point. So it kind of might be working out in our favor. Rich, you had your hand up?
Yeah, I've been thinking about this commission for the last few days, just randomly. And, you know, I although when I listen to it, it can be at times quite frustrating because there are some voices on that commission that, what's a nice way of saying it? Don't seem to know what they're talking about, or something to that effect. I don't know, but at the same time, there are a couple of voices that are extremely knowledgeable, and raise great points. And, you know, for what it is another opportunity for people to get educated by some very knowledgeable people. And it does bring a lot of free advertisement to single payer, right? And so I think that, you know, I agree with you. I think that it is something that you can, obviously it can be frustrating to listen to, but there are some very bright points in it. And I think that it can be something that we can use to sort of our advantage in terms of getting the education out about what single payer means, you know, how effective it can be, you know, how it's been implemented in other places like Taiwan. You know, I think it's something that does have its benefits. And with that, I take care of my baby.
Yeah, no, and I think that I think the facts are on our side and the science is on our side, like the health policy science is on our side. So anywhere where people will look at that stuff, I'm open to that. And so we'll whether, you know, we're drawing to like the close of our office hours. We have like 4 minutes left. But I think one thing that just brought up is if you start to look at the calendar, the political calendar ahead, we now know that the governor's recall election is going to be in September. That this commission is supposed to wrap up its findings by the end of the year, and that AB 1400 is going to be coming up in front of the Assembly Health Committee in January of 2022. So I think that we are approaching a harmonic convergence of stuff on this issue. That we should be like focused and moving towards early 2022 as when all these things will come together, and where our legislature will need to sort of do its thing, or if they do the wrong thing, then people who disagree with them politically will be taking political action in 2022. I think it'll end up being political issues in the races in 2022 if we don't see our legislature doing the right thing. But I also think that there's a lot of forces aimed at doing the right thing. And so that's, you know, one of the reasons why we are going to continue to beat this drum every weekend, and lots of other drums. So we are, we have 2 minutes left. Jeanna, do you want to do any closing thoughts, or does anybody have they want to?
I mean, my only closing thought would be that, you know, like I said, the excuses are that that people may have on why they don't support, why they can't support, why, you know, they're running out of them. You know, we've got to, we've got to get Governor Newsom, we've got to fight the recall. Well, the recall campaign will be over by January. Well, what about the commission? The commission will be over by January. So, you know, there's going to be a lot of the excuses that we're hearing now will not exist later. So what we're going to do is continue to build momentum. And then Rich, I just saw, can we get Carmen Comsty? I would love to have Carmen on here. If she's able to, I would love to, you know, get Carmen Comsty on here just for a little bit to pick her brain. It'd be great. So yeah, if we can make that happen, somebody know Carmen directly, feel free to reach out and invite her to office hours. Or maybe she's already seen us. I know a lot of you guys are watching in the background. But that's all my final thoughts.
All right. Well, Paul, thank you again, Paul Newman, for all your hard work to like get us platformized right this week. We'll try to, we'll try to get word out about what the issues are next week, but we'll be back.
Bye, everyone.
Thank you, everybody.